Thank you, Dr. Veena, for this opportunity, and thank you, KSOS, for having me here. So, if you minimally invasive glaucoma surgery is many people talk about robotics, and robotics. In fact, we have been into robotics for many years, even before robotics actually came up. So, all the SLT we are talking about is actually robotics, and the robotics which we use is actually, in micrometer scale, whereas robotics, when they talk about in general surgery and other branches, is actually millimeter scale. So we are already into robotics for many, many years, especially when you're doing PRP or let's say YAG-PI or any laser procedure. So the advantage why we are talking about SLT so much is if you can manage your failures with SLT, it's very easy to manage your failures with mix. You cannot approach mix without understanding SLT. So it's very, very important that you know that SLT is very important, and at the same time, the corollary is the same. So if you have issues with mix, that means you can overcome that easily because we've been doing SLT for many years. Because you're addressing the same structure, you're addressing the trabecular meshwork in a different way. Here you are going physically and altering it, whereas in SLT you're just doing a laser. So SLT and mix are actually, the aim is the same. The aim is to reduce the burden of medication for the glaucoma patient. One is through laser, which is very, very less expensive. Other is through mix, which is quite expensive, carries the risk of endophthalmitis also, which you don't have in SLT. So if you can learn SLT, it's really very good. The mix and SLT, invariably, they address only primary open angle glaucoma. So I would suggest that if you want to burn your fingers, burn it with SLT first rather than burning it with mix directly. So having said that, so these are all the mix which we have. To your left, you'll have a lot of devices, and to the right is the traditional glaucoma surgery. So in the left, you have non-bleb forming procedures like endoscopic cyclophotocoagulation, which address the ciliary processes, and then you have the outflow channels, implants like the iStent or the Hydrus, or you can excise or cleave the trabecular meshwork to enhance outflow, or you can dilate it using the Omni devices, which are not available in India. So we'll mainly talk about the excision and cleaving of the trabecular meshwork. And the logic, as talked about SLT as well as mix, is to use the natural outflow pathway of the aqueous production and drainage. So which have been so far and been untapped surgically, and it's more physiological. So here, so the natural outflow pathway is actually a pressure-dependent pathway. It's not the uvascular pathway. Uvascular pathway works better in some other animals, but in humans, the natural pathway is the trabecular meshwork, and that by genetics or epigenetics stops functioning at a particular point in time of the patient. So if we can catch the patient early, you can do a SLT, for example, and the logic of SLT is the mechanism is not exactly understood, but the one aspect says that you have stem cells in the non-pigmented part of trabecular meshwork. So since you have a larger spot size of 400 microns, those stem cells start changing and then start populating the pigmented trabecular meshwork also, and they enhance percolation. So that's another rationale which people are thinking about. Why they say that is because the corneal endothelial cells in the periphery of the cornea also starts increasing. So the cellular migration happens anteriorly towards the cornea and posteriorly towards the pigmented trabecular meshwork. So that's another thought which people are thinking about. So this is more physiological mix as well as SLT. So you have certain proprietary devices. So you have the iStent by Glaucos, Hydrus by Alcon. No financial interest in any of these companies. And then for excision, you have the Kahoot dual blade. Trabectome was a device which was being sold in India, but now it's been taken off. And then you have the Tenitos hook. So the I-axis by Glaucos, which is not available here, can be reused, and the Tenitos hook can also be reused. The Trab 360 or the Omni 360, these are the same devices but used for different purposes. So one is you can tear it, or you can viscodilate the Schlemm scanner. And then you have the Mix Plus device, that is that touch the conjunctiva. So we have our own alternative, which is the canaloplasty. Maybe we come to that later. And if you excise the conjunctiva, the pressure flow from Santen is another device. So these are all tubes which are put in the subconjunctival space. So since you don't have that, you have the generic equivalent in India. So for the excision, we use the needle, which is the bang. And if you want to do the tearing part, instead of using the catheter, you can use the GAT procedure. And for Mix Plus, since you don't have a small device, you use the ab external canaloplasty. So for the GAT, you can either use the catheter or the suture. catheter is being developed by the LV Prasad and the Orolab group. And again, for ab external, you can use the suture or the catheter. So you could call them the equivalent generic devices. And for the reasons of economy, we use these along with the stenting devices, which we don't have any alternative to. So these are the photographs of all the devices. You can see this is the first generation iStent, and then second generation, and this is the hydrous implant, and then you have the ECP device, and then the trabectome, and then Omni devices, and then the KDB dual blade. So the main indications are for mild to moderate open angle glaucoma. So it could be primary or secondary, and patients on 2 or more glaucoma medication. The logic is not to bring the intraocular pressure to very low episcleral venous pressures, but to reduce the burden of the medication to the patient. And it can be combined with cataract surgery, can be done individually also. And if the patient is not tolerant to glaucoma medication, or he has some barriers to usage of glaucoma medication, that's another indications. So the main advantage is it's minimal trauma to the conjunctiva. It spares the sclera also, because you don't touch the sclera. And that's a very important structure when you want to do a conventional glaucoma surgery. It's an ab internal device, almost all of them are ab internal, and it's a bleb independent procedure. So you don't form a bleb, so risk of mitomycin C related issues. It's a totally physiological procedure. You have very reduced surgical time. You can always combine it with cataract surgery, and you have very rapid visual recovery with lesser post-operative visits. Very good safety profile. Cosmetically very acceptable. So after MIGS, you could always give a contact lens to your patient, if they want to wear it. When was the last time after glaucoma surgery you gave a contact lens to your patient? I don't think anybody can remember giving a contact lens to a patient. And the most important thing is intraoperative gonioscopy. So for that, you have to be familiar with the gonio lenses. So there are numerous gonio lenses. The Vogue was the one which came out with surgical gonio lenses initially, that what we're familiar with. But outside, you used to get the Ocular Hill gonio lens and then Swan Jacob also. So the Ocular company sells both the Hill gonio lens and the Swan Jacob. You could get any of them. They cost about 50,000 rupees each, and it takes about a month for you to procure it. We have the Ocular Hill, and that you see on the left hand side here, and that's the Ocular Hill gonio lens. And here, this is on your right hand side is the S Prism gonio lens. That's by the Glaucos company. So if you buy a set of eye stents, they'll give you this lens for free. Otherwise, its cost is about 7,500 rupees. You have non-handled, that is a self-retaining gonio lenses. So one is by Ocular, that is known as Secure Flex. Other one is by Catina, that is also known as Coriza lens. So these are some lenses which you can procure. Any company which sells these products, they can help you with the gonio lenses. For the GAT procedure, you need Prolene sutures. So we have the 50 and the 60 Prolene suture. Orolab used to make them and give it to us separately, but now we get the sutures from the regular supplier, which could be Orolab, but we make the suture ourselves. So blunt the tip ourselves using a thermal cautery. So we do that in the OR. Orolab have stopped selling it, mainly because now they have to go through the DGCI to get a license to market it. Angle anatomy is very, very important. I showed this slide yesterday also. So normal angle anatomy is what we target for our primary open angle glaucoma patients for SLT as well as for MIGS. So you should see a sliver of ciliary body band for all your patients. So if you don't see the ciliary body band, that means the iris is anteriorly inserted, it's abnormal iris. Your MIGS or your SLT will not work so satisfactorily. You may get a paradoxical raised IOP after you touch those angles. So you have to be very, very careful. The featureless angle which is shown here, this is the most risky. The anatomy is, we have operated some of them, we have never been able to cannulate those angles. So the suture doesn't go into it at all. You keep incising, cutting, the suture will never thread. We really don't know what exactly is wrong. We are going to get an ASOCT, then maybe we'll start looking into these eyes. The third one is the high iris insertion. So this is again easy manageable. Easily manageable, mainly because if you decompress the globe, you will find blood in the Schramm's canal. So you can see where the trabecular meshwork is. And prominent iris processes are again easily identifiable. The trabecular meshwork behind that is easily identifiable. So these can be easily tackled. The most difficult ones are the featureless angles. So I would strongly recommend not to do SLT in these eyes or MIGS in these eyes. So stenting the canal was the first prototype device which was launched way back almost 2007, and this is the second generation, and you can see that the device is like a collar stud. So it has a flange and then a thorax and a head. So this is the flange at the bottom, and then you have the thorax and the head, and the central lumen which percolates here is about 80 microns, and the side lumens are about 50 microns. So the logic is that you insert it into the trabecular meshwork, and it allows aqueous humor percolation into the Schlemm's canal. So this is how the photograph looks like if you have inserted it, and then you can see blood coming out of the stents, and then you tap it. It comes preloaded in. So once you decompress, you can see the blood in the Schlemm's canal. So that's a very good indication that you have selected a very nice case. You can see the sliver of ciliary body band. You see a nice trabecular meshwork which is filled with blood. The Schlemm's canal is filled with blood. That's 3, and then you can see the slight, shawl base line at the top. So it comes preloaded, and then you shoot 2 devices, one after the other. So it requires a little bit of learning curve, but otherwise it's very easily performed. And then you turn around. The idea is to insert the inferior one first, and then do the superior one. So if you do the superior and the blood regurgitates and then it blocks the view, then you won't be able to do the inferior again. So do the inferior one first, so that the blood goes down because of gravity, and then you can shoot the second one. It is quite costly, so we offer it to patients with mild to moderate open angle glaucoma who have insurance, and that's the end of the procedure. Coming to excisional goniotomy, the traditional versus excisional is you have the needle-based device or the MVR-based device, but you have the Kahook dual blade now. So these are quite sophisticated devices. It has it has a ramp and then 2 blades at the side. So as you introduce the ramp into the trabecular meshwork, the knives which are at the edge cut the trabecular meshwork, and the strip of tissue is peeled off. Very sophisticated, very good results. We are very happy with it. And this is how it works. So you can see when we have a small nodule there, iris trabecular meshwork nodule. So we can do this on either side of the nodule. I think okay, we'll just let it play. It's blocked. Slower. Stop हो रहा है. Stop कर दे. Yeah, after that. After that. After that. Next. Next. Yeah, that one. Just to the middle. Yeah. It stops, huh? It's slower. Okay, so we play it from the beginning. So you can take the blade and cut on either side. I'll come to the next one, which is the Tanitos microhook. Like I mentioned, this is reusable, and the logic is the same as the dual blade. You can incise 120 degrees of the trabecular meshwork on the nasal part. You have 3 instruments. One is a straight and 2 are angled. So the angled one are for the approach from the supranasal aspect into the temporal region. So there you can incise 120 degrees. So if you are not happy with, let's say, 120 degree incision. You can always do one more 120. So for people who are not able to do a complete GAT, this is very useful. So you have a 240 degree excision compared to a just 120 degree excision. So the logic here is that everybody knows that the nasal area is filled with collector channels, but the ones on the temporal side can also be recruited for functionality. If you excise the ones on the nasal temporal side, they also start functioning. When you do for a diseased eye, you find more vessels on the nasal side. That doesn't mean the temporal side is not present. It will be present, it just starts shutting down. So you do that, and that's why many people say GAT works better than bang. So this is another video where video of my friend, Dr. Devendra is, so after the phaco is over, this is the infratemporal angle which is approaching. You can see the ciliary body band and then the scleral spur, and then you just incise just like a hook dual blade. So this is again a reusable device. It comes in 3 pairs. I think the APAO meeting in Delhi, they are going to launch this. The company is going to launch it in India. Then you can purchase it. As of now, we got it complimentary of the manufacturer. Some of us have got it, and we used to purchase it from outside. So this is the left being done, and then you can do the right similarly. The supranasal, infratemporal angle, supranasal approach. So you have to sit on the opposite side of the patient and then do the procedure. Bent ab interno goniectomy is another simple device. This is very commonly done, very less expensive, and you just bent the 26 gauge needle or 24 gauge needle and then strip the nasal part of the trabecular meshwork. Gonioscopy assisted transluminal trabeculotomy was addressing 360 degree of the problem, and you thread a suture into the Schlemm's canal. It could be a 5-0 or a 6-0. Because the anatomy is so distorted, we always keep both the sutures together. Patients who have been chronically medicated, we use a smaller bore suture, which is a 6-0. Patients who have recently been diagnosed, their Schlemm's canal is not so small, so they can accommodate a larger suture, that is a 5-0. So we keep both the sutures ready, and then wherever is necessary, we use that. Sometimes 5-0 suture doesn't go in. We use it with a 6-0 suture. And once the suture is seen on the opposite side, you catch hold of it, and then you bring it out and tear the you can see the suture in the Schlemm's canal. Bring it out and then do a trabeculotomy. So the whole suture gets, you remove the gonial lens and then you grasp hold of it and then you tear the trabecular meshwork. So this is the eyes, the left eye on the left side is done 1 year back, and this is done recently. And you can see that we always leave 40% fill. If you have done extensive cutting over the trabecular meshwork, you always leave 40% fill of oro gel, which is sodium hyaluronate in the antechamber. But if you have done limited goniotomy or limited excision, we don't need to do that. So the merits of mix are numerous. You have better quality of life, spares the conjunctiva, it's very cost effective. And the demerits are you could have only a modest ability to reduce the intraocular pressure. It doesn't achieve low IOP and cannot be modified unlike TRAB. So you cannot do a suture removal or bleb needling or anything. So if it's done, it's done. You have to go to plan B for that. So say case selection is very important. So mild to moderate glaucoma is the ones which we usually do mix for. And if you have to combine it with cataract surgery, make sure you do a uneven full cataract surgery in these eyes. So don't touch the iris too much, avoid pigment dispersion, and deepen the chamber with sodium hyaluronate. And extensive mix, always like GAT, always leave sodium hyaluronate, which is 40% fill. And limited mix like KDB, Bang, Tanitos, don't leave any OVD in the chamber. Be careful of patients who have limited hypertension control or or anticoagulants, or they have fluctuating BP. So this is very important thing which you have, because they have a tendency to bleed later on. So I'll stop here for want of time. Any questions, happy to take. Thank you.
So, what is your experience regarding the hyphema which develops after GAT procedures?
So the GAT procedures, we always leave 40 to 50% fill of sodium hydrate. When you do that, you don't get hyphema.
And what about the delayed hyphema? Have you seen
Delayed hyphema,
cases
we
of
have had
delayed
patients.
hyphema?
Yeah, we have had patients with pseudo exfoliation syndrome and patients on anticoagulants. They are the two patients who develops delayed hyphema. They can happen about 3 months later also. So for them, we ask them to just take rest with the head end elevated, and then it resolves on its own. There's no active intervention that we have to do, but we ask them to take rest for a day or two. It can quite sudden. It can happen. In that, supposing they were driving or something like that, they can be really debilitated because of that. That's something which we have to think of. So hypertensives, we're very particular that either they're on chronic medication and have a very good control, or we have a plan B for those patients. We do a canaloplasty.
You have a very good experience regarding canaloplasty.
Yeah.
I would have loved to ask you some questions about it, but I don't think we have
In
enough
the
time
time,
for that.
maybe we'll discuss later.
Sir, acute postoperative IOP rise after the sodium alginate and hyphema will be there if.
Yeah, if you believe more, like there's a little calculation which we have to do. In fact, you could also get a on-table tonometer, which is used by LASIK people for checking the intraocular pressure. So you have those tonometers, which are Baraka tonometers. They are based on the Glaucoma model, and they are fixed area tonometers with variable force. So since you have them, you can leave the pressure at 30 millimeters of mercury. Okay, they don't cause any problem. But when you do overfill, that day, same day evening, patient will have raised IOP. So we can burp the wound on the slit lamp. That we have done. If necessary, we do that. So we put a drop of povidone iodine, and then you have incision through that, take a needle and burp the wound. Immediately they have a relief. So that is how we manage. But now we are trying to, mix oro gel with irrigating solution and leave about 40% fill. Thank you.
Thanks.